Okay, going to talk about oxygen therapy. We know oxygen is tasteless and colorless gas. It accounts for 21% of atmospheric air, so just in the air we breathe every day, there's 21% of oxygen in it. It is used to maintain adequate cellular oxygenation, and we use it to treat many acute and chronic respiratory problems. We want to keep an SaO2 of at least 95 to 100% by using the lowest amount of oxygen without putting our patients at risk for any complications. Now let's talk about the different delivery devices that are out there. This is just going to be a review, and you're going to learn a couple new things maybe. It can be delivered in a variety of methods based on each patient's particular need. And when we deliver oxygen, it's expressed as a fraction of the inspired oxygen, which is an FiO2. So low delivery systems vary the amounts of oxygen you can give. A nasal cannula is the one we're all familiar with. It's a length of tubing with two prongs that go right into the nose. FiO2 24 to 44% flow rates at a rate of 1 to 6 liters per minute. It's safe, easy to use, it's comfortable, patients tolerate it well, they can talk, eat, drink, ambulate with it on. The FiO2 does vary with the flow rate and the patient's rate and depth of breathing. And if we use it for a long period of time, we can break down their skin and dry out their mucous membranes. And the tubing is easily dislodged, and you've seen it come out very easily. So when we're using it, we want to make sure they have patent nares, that the prongs fit in properly. We all know there's an upside down way to put it in. We want them to curve with the curve of their nares. So make sure your patient has it in right, otherwise it's just going to be pushing the oxygen's going to go more onto their membrane than down into their airway. We can use water-soluble gel to help prevent their nose from drying out, and if it's greater than 4 liters per minute, we want to put it on a humidification, humidify the oxygen, just much more comfortable for the patient and decreases breakdown. Okay, the simple mask that covers the patient's nose and mouth, and that is an FiO2 of 24 to 44 with flow rates of 1 to 6 liters. The minimum flow rate is 5, and that has to happen to ensure flushing of CO2 from the mask, because they're going to be exhaling as well into that. It's easily to apply. It's more comfortable than the nasal cannula. And you know what? I need to tell you guys that the length of tubing that you put on these patients doesn't make any difference. So you can have 50 feet of, well, that's kind of an exaggeration, but you could have 3 feet of oxygen tubing or 10 feet. It's still going to deliver the same amount of oxygen. So back to the face mask. The disadvantage, definitely, if you have a flow rate of 5 liters per minute or lower, it can result in rebreathing CO2, which we don't want. It's poorly tolerated by patients who are anxious or are claustrophobic in any way, and often those are the patients who have trouble breathing. It freaks them out to have something over their nose and mouth. They can't eat, drink, or talk with it on, and you want to make sure that you use caution if your patient has high risk of aspiration or airway obstruction. Make sure that it fits correctly, that it seals well over the nose and mouth, and not sealed like suction onto their face, but that there's not a lot, it's not hanging off of them, that it's going where it's supposed to be going. And if they're typically wearing a face mask and then they're going to eat or drink, you want to switch them over to a nasal cannula when they're eating their meals. The partial rebreather mask that covers the client's nose and mouth, that's there on the bottom of the slide. FiO2 60 to 75% with flow rates of 6 to 11 liters per minute. The mask has a reservoir bag attached with no valve. The non-rebreather has valves. You see that on the right has valves, but the partial rebreather has no valves. and allows the patient to rebreathe up to 1/3 of exhaled air together with room air. So the disadvantages of this is complete deflation of the reservoir bag during inspiration causes the CO2 to build up. The FiO2 varies with the client's breathing pattern or the patient's breathing pattern. It's poorly tolerated by the anxious and those who have claustrophobia. They can't eat, drink with it, talk. It's difficult to understand. And then we want to be careful if they have an aspiration risk. So we want to keep that reservoir bag from deflating by adjusting the flow rate to keep it inflated. So the partial rebreather, that does need to remain inflated, the bag. And we're going to know that the FiO2 is going to vary with their breathing pattern. We're going to make sure it fits on the nose and mouth, and then switch them to a cannula during meals. Now let's look at the non-rebreather, which is on the top of this slide. And it is an FiO2 of 80 to 95%, and it delivers the most oxygen without intubation. It has the valves in place. The flow rate must be 10 to 15 liters to keep that reservoir bag 2/3 full during inspiration and expiration. It will deliver, like I said, the highest oxygen concentration possible, except for if you intubate the patient. And the one-way valve between the mask and the reservoir allows the client to inhale the maximum amount of oxygen from that reservoir bag. And then there's 2 exhalation ports on either side that prevent, they have flaps, and that prevents the room air from entering the mask, so they get the most oxygen. You have to make sure that the valve and the flap on the mask are intact and functional during each breath, and it's poorly tolerated by anxious or claustrophobic patients, so it has its disadvantages. You want to make sure that you're assessing for those flaps and valves to make sure they're intact, that they have a good seal over their mouth and their nose, and typically they're not eating or drinking or talking when they need that much oxygen, but if they do, you want to switch them to the nasal cannula during meals. The high flow oxygen delivery system delivers precise amounts of oxygen when it's fitted properly, and that's the Venturi mask. It covers both the nose and the mouth. It delivers an FiO2 of 24% to 55%, and the flow rates 2 to 10. And they have different size adapters which control that. It delivers the most precise oxygen concentration. So the Venturi mask matches patient demand. It's really good for CO2 retainers. We like these for our COPDers. Humidification is not required. Chronic lung disease patients, it's the best one for them. It's expensive, and you need to make sure the correct flow rate is going. Make sure there's no kinking in the tubing. But usually it's 24 to 50%. Like I said on this slide, some have up to 100% running at flush. So Venturi mask, ideal for COPD, chronic lung disease. Our other systems that we have here, like the aerosol mask on the right, face tent, that's down on the left. These fit loosely around the face and neck. The trach collar, you see it up there on the left. And it's a small mask that covers that trach. All these masks have FiO2 of 24 to 100% at flow rates of at least 10 liters per minute. They provide high humidification with oxygen delivery. They need to be on a humidifier. All of these things. The aerosol mask, we see that for delivering of a medication. You'll often see the respiratory therapist in the hospitals put the medication in there. You see the little piece, and they give the breathing treatment that way through the aerosol mask. We're going to practice that also in our skills lab simulation day. So these methods are good for different reasons. Usually if a patient can't tolerate a mask, if they've had facial trauma, burn, something like that, thick secretions, we'll put the face tent on them. There's a lot of condensation that gets in the tubing with these, especially the trach patients, and then the tent, you see, with the corrugation. So we have to make sure that we dump that condensation away from the patient. Don't put it towards them, otherwise you will flush their trach or give them a wet face. So the aerosol mist, ensure that it leaves from the vents during inspiration and expiration. On the aerosol mask, you don't want to have, you want to see the mist coming out. You don't want it sealed off, because then they're going to be rebreathing. And with the trach, you want to make sure that it's not pulling on the trach mask is not pulling on the trach itself, so that there's slack in it. That T-piece we see down there on the right-hand side, the patient has to be intubated for that. It's 24 to 100% as well, and at least 10 liters. And it's typically used for trachs, laryngectomies, or endotracheal tubes. It's a blow-by. They also call it blow-by, the T-piece. It can have aerosol put into the tubing down further, not right at the T-piece itself, but perhaps where that arrow is where you would put the aerosol in if you needed to do medication administration. But you want to make sure that the weight of it doesn't pull on the trach or the ET tube, and you want to make sure that the mist, if you're giving a treatment, is coming out of the end piece there, the one on the right. So if you see the O2 going in where the arrow is on the left side, there's right under the word intubated on this slide, you're going to want to be seeing mist coming out of there. If it's a treatment's in place, you want to make sure that you can feel that it's going out, because we don't want them rebreathing. And this slide I made just to show you some other forms of oxygen delivery. The baby there under the hood, that's a head hood. Often they'll put those over newborns. You probably saw them during your OB rotation. You got to be careful that the baby doesn't get too cool with that. The pendant, or the reservoir nasal cannula, it holds some oxygen down. There's a reservoir there. Sometimes you'll see old COPDers will have these pendants. Biflow, I don't have that up there. The mustache one, that's the Biflow one. I do have that up there. That's that little mask that the photograph has on. It's a mustache mask. It delivers a Biflow. And then the trach catheters, those are kind of interesting. They go right into the trachea. You see how that has a tiny little tube that goes right in. And incubator, I don't have a picture of that. Don't have a picture of hyperbaric chamber. But there's a croup tent there on the left-hand side. And that was one of the earliest ways of delivering oxygen, typically for infants with croup and children. Like everything else, there's complications of oxygen therapy. Oxygen toxicity, it's a result from high concentrations of oxygen, typically greater than 50%, for a long duration of oxygen therapy for more than 24 to 48 hours. And that also is based, it's related to the degree of lung disease the patient has. So the signs and symptoms of oxygen toxicity is a non-productive constant cough. They may have substernal pain, nasal stuffiness, increased shortness of breath, dyspnea, nausea, vomiting, fatigue, headache, sore throat. You can have hypoventilation as well. So we always want to make sure that we're using the lowest level of oxygen therapy in order to maintain an adequate SaO2. We're going to keep an eye on their ABGs. We're going to let the doc know if the SaO2 levels are outside of our expected reference range. We're going to use an oxygen mask with continuous positive pressure, CPAP, or a BiPAP, bilevel positive airway pressure, or PEEP, on our patients who are mechanically ventilated to help decrease their need for oxygen. And you're going to have that more in 4th semester. Oxygen-induced hypoventilation can develop with our patients who have COPD and chronic hypoxemia and hypercarbonemia. I hate that word. Hypercarbia. Anyways, the clients who have COPD rely on low levels of oxygen. That's their primary drive for breathing. We typically, people who do not have lung disease are driven by the CO2 concentration. Patients who have COPD, they rely on their arterial oxygen. And if we give them too much oxygen, we can decrease or eliminate their respiratory drive. So we have to be really careful about how much oxygen we give to our chronic patients who have chronic lung disease. We want to look at their rate and pattern, their level of consciousness. Always give therapy, oxygen therapy, as the lowest flow rate to correct the hypoxemia. If they can, we're going to put a Venturi mask on them to deliver precise oxygen levels. Now, remember I said this is the best mask for patients who have COPD. However, they are the ones that don't like the mask because it's claustrophobic to them. So it's a catch-22 for these patients. And if we're seeing respiratory depression, we're going to get ready to intubate. We're going to let the doc know. We're going to see that there's a decreased level of consciousness. They're going to start to decrease their rate of respirations. And we're going to think about getting ready to intubate and prepared for that. Final complication is combustion. No smoking around. No smoking, Brother Bob. No smoking around oxygen. We want to post no smoking signs, oxygen in use, let everybody know where fire extinguishers are. This is important at home, patients on home O2. We all know stories of the old COPDers at home that turn their oxygen off and go and have a smoke or blow themselves up, set themselves on fire. We want to make sure that they know that it's a fire hazard. That they're wearing cotton because synthetic and wool fabrics can generate static electricity, and if they're wearing oxygen and they got little sparkies going off, they could have a little burn that way. Make sure anything they're around, electric devices, are working well. Anything that has batteries in it, like radios, razors, hearing aids. Things are grounded. Any monitors, suction machines, everything has a ground to them, and we don't want them to be around volatile, flammable materials like acetone or alcohol. If they're on oxygen, we don't want to be messing with that around them. So make sure you educate your patient about those risks.